After 3 years of pandemic, we now finally return to the face-to-face meeting of our annual Diabetes Preventing the Preventable Forum. I'm very pleased to report that we have 400 people registering for the meeting. During this meeting, we talked about the preventable natures of the eyes and feet complications. We talked about the different strategies and technologies used to prevent complications. We talked about the importance of understanding your patient's quality of life in order to provide holistic care. And most excitingly, we have invited our Commissioner for Primary Care Reform to talk about the co-care program in the prevention and control of diabetes and chronic diseases. So we hope that what we have learned today can be translated to practice for the betterment of the health and also the quality of life of people with diabetes and those at risk.
Today I'm going to share the new technologies in preventing blindness from diabetes. Diabetes is a very common disease in Hong Kong, affecting approximately 10% of the population. Approximately 40% of our patients have diabetic retinopathy, and 10% of them have vision-threatening diabetic retinopathy. Without treatment, they are very likely to go blind. Fortunately, now we have new tools in our fight against blindness from diabetes, including ultra-wide-field imaging, OCT angiography, and artificial intelligence. I'm going to share how we're going to use these new technologies in our fight against blindness from diabetes today.
We all know every 30 seconds a diabetic foot is amputated somewhere in the world. According to WHO, diabetic foot problem is the most common, costly and severe complication of diabetic foot. And we all know that around 30–80% of diabetic foot amputation is preventable. We have done really well locally in order to reduce the number of ulcerations and lower amputation in Hong Kong through the RAM program. And how about the multidisciplinary approach in Hong Kong? We are going to discuss and review more in the coming panel discussions and also presentation.
Today, I share with the audience with the latest research on the use of vitamin C, vitamin D, and NMN on the prevention of type 2 diabetes.
Pancreatic beta cell failure plays a major role in the development and also the progression of type 2 diabetes. In the talk today, I share with the audience the evidence of using insulin therapy in the diagnosis early in the diagnosis in diabetes, especially in those who are already very hypoglycemic in beta cell rescue. I also shared in the use of early insulinization in patients already with long-standing diabetes but who are failing to reach target control to help them minimize the risk of progression into complications due to newer diabetes availability of insulin therapies that have low risk of hypoglycemia and relatively easy to initiate, such as second-generation basal insulin analogs that can be used together with oral hypoglycemic agents. Also shared with them the use of basal plus concept and how to initiate insulin therapy.
Today, I'm honored to be invited to talk about treatment simplicity in diabetes management. Treatment simplicity is an important but under-recognized aspect in diabetes care. I'm happy to have this opportunity to introduce a new addition of therapy, fixed ratio combination with insulin glargine together with lisasenatide in the addition of the care of patients with diabetes.
In my lecture, I talked about quality of life and diabetes treatment. Quality of life is a very important attribute that can affect a person's health as well as their health behavior. Using the JADE register involving more than 40,000 patients treated with oral drugs, we found that patients treated with sulfonylurea had worse quality of life compared to those people not treated with sulfonylurea. But interestingly, amongst the sulfonylurea treated patients, patients treated with glycoside had better quality of life. And this may be related to the better A1C control, lower risk of hypoglycemia, as well as better control of hypertension and dyslipidemia. Other determinants of quality of life include, for example, men, young people, healthy exercise and also diet. These are associated with good quality of life. people who are obese, have long disease duration, have complications, have worse glycemic control, have poor quality of life. So I think these data highlight the importance of measuring a patient-reported outcome in order to treat the patient in a holistic manner and to choose the medications in an effective manner to maximize the impact of the care on this individual.
Today I'd like to share with you the latest insights using time and range for assessment of glycemia. We recognize that we need to go beyond HbA1c to try to minimize glycemic excursions. I will illustrate some examples of how we do that and how we can best use newer insulins to try to optimize postprandial glucose control.
Currently, there are several classes of anti-obesity drugs approved for the long-term management of obesity. Orlistat is a gastric and pancreatic lipase inhibitor. Some are appetite suppressants, such as Contrave, Qsymia. Some are GLP-1 receptor agonists, such as semaglutide, liraglutide. Some newer agents, such as GIP and GLP-1 dual agonist, tirzepatide, looks rewarding to treat obesity, and it can lead to up to 21% weight reduction. In this talk, I will review the efficacy and safety of the currently approved medications and discuss future therapeutic approach of treating obesity.
Although novel oral drugs such as SGLT2 and GLP-1 antagonists significantly improves obesity and reduces NCDs, they may not be cost-effective at its current pricing as first-line treatments, substituting for metformin. Whereas a good risk screening program such as JADE, in combination with a public-private partnership program with personalized education follow-up, will save money and reduce NCDs as compared to a public hospital care program.
About my talk, which is on continuation of care and RAM-DM in primary care setting, the summary points would be, we all know that diabetes population is on a rising trend and our diabetic patients are getting older. So the complication rates will be on increasing trend as well, and that could cause a great impact on the overall healthcare cost. And in order to prevent that in primary care setting, we know there are several important ways we could do, and that includes a comprehensive complication screening like RAM-DM. We already know that this is a very cost-effective program. And together with that is patient empowerment and also individualized management for our diabetic patients. And all these together could help to improve the diabetic control of our patients. And of course, both the public setting and the private setting should work together as a team to help to manage our diabetic patients.
Talking about the changing trend of diabetes care, I think we are at least seeing 4 different trends. The first one is we are moving away from a glucose-centric approach to diabetes care to actually organ protection. And also we are looking into different underlying pathophysiology of our patients in order to tailor-make our care. Secondly, we are offering more personalized care to every diabetics and every patient with diabetes, because no 2 patients with diabetes are the same. Thirdly, we are actually using more apparatus or machine like CGM to help our diabetes care rather than only using the drugs to help our patient. And lastly, we are very excited to know that nowadays diabetes is not necessarily a permanent condition. We are seeing more and more people we are cured of their diabetes. And of course, diabetes is very preventable, and also it has a chance to be cured.
Thank you so much to invite me as one of the speakers to share the government new initiatives on chronic disease co-care program under the primary healthcare reform. The primary healthcare reform includes the family doctors system as well as the primary healthcare in district. So we would like to work hands in hand to prevent the chronic disease, start from very early of the disease. Like for diabetes, we not start from the diagnosis, we start from pre-diabetes. We hope that we can work hands in hand together as a part of the community with the private and public as well as all disciplines of the different background professionals to work together to improve our disease management in Hong Kong.
My presentation today will be about to give my recommendation to the relevant bureau on the measures to prevent the onset of future diabetes. that we will give advices on the how to pick up the high-risk individuals, and also after picking up the high-risk individuals and also the undiagnosed diabetes, how to implement early treatment and also measures to prevent the onset or even delay the onset of diabetes in the high-risk individuals.